My name is Sandeep Athala. I am the Senior Program Associate with the Environmental Change and Security Program here at the Woodrow Wilson International Center for Scholars. The Environmental Change and Security Program, or ECSP, is 19 years old, and we look at the various connections between health, environment, livelihoods, population, and security. Today's event is brought to you as part of our HELPS project, which incidentally stands for those words I just used: health, environment, livelihoods, population, and security. HELPS is a 5-year effort generously funded by the United States Agency for International Development, or USAID's Office of Population and Reproductive Health. As many of you know, the Wilson Center is the formal memorial to our 28th president, the only president thus far to have achieved a PhD, and in his honor, here at the center, we aim to bring the worlds of policy, practice, and academia together to better inform one another. A note about today's event: we are being webcasted live, so when we come to the discussion part of today's event, I'd ask that you use a mic, and my colleagues will be around the room with them. I'd also ask that you introduce yourself and your affiliation. Before I turn it over to our esteemed moderator, Monique Widiono, the technical advisor for gender at USAID's Global Health Office of HIV and AIDS, I want to thank Pathfinder, as well as the Center's Global Health Initiative and Africa program for today's event. So thank you.
Okay, can everyone hear me? Great. Thank you so much, Sandeep. And I'd love to also begin by thanking you and the Woodrow Wilson Center for sponsoring this, I think, very timely event, and to join you on behalf of USAID's Global Health Bureau in welcoming our panelists and all of the participants. It's really nice to be back here at the Woodrow Wilson Center. I see some of our colleagues from the IGWG, the Interagency Gender Working Group, with whom we've partnered on a number of events here, so it's great to be back in this space. Before introducing our speakers, I'd love to just take a brief minute to highlight from the USAID perspective why we feel this conversation has such resonance for our global health efforts. And to start maybe with just a few snapshots of data. About 16 million girls ages 15 to 19 and 2 million girls under the age of 15 give birth every year. And the majority of these births occur within the context of marriage. And more than 30% of girls in what we categorize as developing countries are married before the age of 18, and around 14% before the age of 15. So this is a very, very important consideration for us as we think about our health efforts. And unprotected sexual activity contributes to a number of social risks and negative health outcomes for many young women and young adolescent girls, including, as the majority of us probably are engaged in addressing issues such as early pregnancy, STIs, HIV infection, obstetric fistula, unsafe abortion, nutrition outcomes, and gender-based violence. And the data that we are seeing suggests that unmet need for family planning is often high among sexually active adolescents who want to postpone pregnancy, particularly married adolescents who may be under pressure to demonstrate fertility or under pressure as a result of other normative expectations. So one of the things that I wanted to just highlight is USAID's framework for what we're doing to really commit and understand and really think about our programmatic work that addresses this unmet need. Our Youth in Development policy, recently released, really highlights the agency's commitment to programmatic initiatives that engage youth at the center of our work and not just as beneficiaries. We also have a gender equality and women's empowerment, female empowerment policy, again, which many of you hopefully have heard of, which really looks at USAID's understanding of and commitment to addressing gender inequities and really promoting gender equality. And why is that so important? Because we're beginning to unpack the role that gender norms and inequities play in affecting health outcomes. And fostering risk and vulnerability, as well as unmet need, not only in the context of family planning, but of course, related outcomes, reproductive health, maternal and child health, gender-based violence, HIV. So it's really important to be thinking about the role that addressing gender can play in our programmatic work. And how does this sort of play out in the work that USAID has been implementing and supporting with respect to addressing the unmet need for women and girls and the need to really look at gender inequities? We are working on a number of activities, or supporting a number of activities that really elucidate how these norms can be addressed. And I'm just going to throw out a few quick examples. For example, the GREAT project in Uganda, Gender Roles, Equality, Transformation Project in Uganda, Stepping Stones in South Africa, and in a number of other contexts, are really shedding light on how youth can be engaged in conversations around addressing gender norms, and how those conversations can be translated into improved health outcomes. I also want to just quickly highlight that we do have a child marriage strategy, part of the sort of the gender architecture that has been supported by USAID over the past couple of years. And that outlines our agency's commitment to preventing child marriage, but we also really recognize that married girls are the ones that are very much at risk. And they're the ones that are often not necessarily at the center of the efforts to really look at unmet need for a variety of reasons. So I just wanted to give that really brief overview before introducing our speakers, welcoming and introducing our speakers. Love to start with Carrie McQuarrie, a senior research associate with Measure DHS and a member of Futures Institute. Prior to working with Measure DHS, she worked with the International Center for Research on Women, the World Wildlife Fund, Save the Children, and SEDPA, conducting research and program evaluations related to adolescent reproductive health, women's empowerment, domestic violence, gender and conservation, and abortion and stigma related to HIV/AIDS. She is a PhD candidate and earned her MA at the University of Washington, where she was trained as a social demographer. So, Carrie, I'd love to turn it over to you.
Is this the right level? Okay. Okay. All right, thank you very much for that kind introduction. I will be presenting today preliminary findings from a comparative report that the DHS is releasing titled Unmet Need for Family Planning Among Youth. Unmet need for family planning is a fairly narrow concept, but it's a very fundamental one in the field of reproductive health because the ability to control one's fertility is so core. It's also used as an indicator in numerous international monitoring and national programmatic efforts. And one of the things that these data can do here today is help to determine where the needs of young people need to be prioritized. Oops, sorry, there we go. The data that I'm using today comes from the demographic and health surveys. 61 different surveys, current surveys, from countries that have had a demographic and health survey conducted since the year 2000 for married women. This means for West and Central Africa, 18 surveys, East and Southern Africa, 14 surveys, Middle East and North Africa, 4, Eastern Europe, 7 countries, Asia, 10 countries, and Latin America, 8 countries. I'll be focusing on the African data here today. For unmarried women, fewer of our surveys collect data related to unmet need among unmarried young women, and so those data come from just 41 countries. The report that will be coming out will be presenting data on trends, and that uses prior surveys for a total of 141 surveys collecting data on married women, 90 surveys on unmarried women. And one important note is that these data will be using the latest definition for unmet need that the DHS calculates. Just to give a brief outline of what my presentation today will cover, I will be looking at current situations related to unmet need for family planning among married youth. There is a section in the report on trends among married youth, but I will not be presenting the trends data here today. I will then go into some comparisons by age, looking both within and among young women and comparing young women with women of older reproductive age. And then looking at the current situation and in the report only trends among unmarried youth. And then looking at unmet need by a number of sociodemographic factors, such as residence, wealth, and education. Finally, the report, but not the presentation, has a chapter on the different components that go into unmet need, examining marriage and sexual activity patterns, fertility desires, and contraceptive use. And as I mentioned before, the report looks at the global context. What I will be focusing on here today are those data from Africa. So before we go on, just a technical note. Unmet need is commonly understood as the proportion of married women of reproductive age who want to delay or want no more children but are not using contraception. This fairly simple concept, however, results from very complicated calculations and algorithms. We use married women as a proxy for exposure to the risk of pregnancy, but there is a corollary for unmarried women using sexually active within the last 30 days. The DHS algorithm changed recently, last year, and there's a report on this. These changes were made so that the new estimation would be more streamlined and so that it would be consistent and comparable across surveys over time and across countries to assist in international monitoring efforts. These changes resulted in an upward adjustment of estimates of unmet need. For all of the DH surveys for which this adjustment had been applied, it increased the proportion of women of all reproductive age having unmet need from 21.3% to about 23%. These charts show just a few case examples of what that change looks like for some individual countries. And we see that most of these changes in the estimation technique involved how fecundity and postpartum amenorrhea were considered using the calendar data that was collected in certain surveys. And so we see that the biggest changes are in those countries where calendar data had been collected. If you want more information, if you're a DHS data user, there's a report that details these changes. StatCompiler, the utility on DHS's website, now has the new definition in all of its data, and all data sets since mid-year last year now include the new variable for unmet need. If you're using an older data set, you can get STATA or SPSS code to create that new estimation. You don't need to do it yourself. Okay, end of technical note, and now on to the substance of today's talk. Want to look first at the current situation among married women. And this map indicates that globally, the highest rates, which are the darker colors, of unmet need for women, young women, ages 15 to 24, are found in Ghana and in Haiti. The deeper orange colors indicates that unmet need is frequently higher throughout much of Africa and in pockets in selected countries and other regions. This chart here shows total demand for family planning. That is unmet need plus current use of a contraceptive method. And it provides regional averages from those study countries that have a DHS survey. It's not an average for the region as a whole. And it's disaggregated by the two youth age groups for which DHS collects data. It's important to note that the DHS does not collect data on any respondents below the age of 15. So we're looking at 15 to 19-year-olds and 20 to 24-year-olds here. Looking first at just the red bars, which is unmet need itself, we see that the highest levels on average occur in West and Central Africa at approximately 30% among these age groups, with Eastern and Southern Africa, Latin America and Korea, and Asia clustered just below that. In most regions, on average, unmet need for the two age groups is higher among 15 to 19-year-olds, but this is not universally so in all of the countries within each of these regions. The differences, however, are not especially large except for in Latin America and the Caribbean. Now, turning to the gray bars, that is total demand. Total demand is highest in the Latin American and Caribbean countries. Comparing the two African regions that I'll be discussing today, we see that while unmet need is higher in West and Central Africa, total demand is higher in East and Southern Africa, with a larger portion of that demand being met through the use of a family planning method. It's worth pointing out, though, that the proportion of demand that is satisfied is still quite low overall in these two regions. Only 25 to 35% of demand is satisfied among 15 to 19-year-olds, and higher, 49 to 59%, among 20 to 24-year-olds. Okay, looking now specifically at countries within these regions, turning first to West and Central Africa. The following chart allows us to take a closer look at unmet need among these two age groups. And again, we see that Ghana clearly has the highest levels of unmet need in the region. However, among 20 to 24-year-olds, Liberia and Sao Tome rival Ghana's levels. These levels are much lower in Niger, Nigeria, Guinea, and Chad. Comparing the two youth age groups, we see that no one age group is consistently experiencing greater unmet need than the other. However, where the differences between the age groups are largest, unmet need is greater among the youngest age group, 15 to 19-year-olds. This is the case in Congo-Brazzaville, Gabon, Ghana, and Sao Tome. Just a quick note on unmet need for spacing versus unmet need for limiting. I'm not making a distinction in my presentation because among these age groups, the overwhelming amount of proportion of unmet need is unmet need for spacing. Unmet need for limiting in these age groups is generally less than 2%. Nonetheless, there's a noteworthy exception to every rule. Around 10%, there's approximately 10% of unmet need for limiting in Ghana and Sao Tome and West and Central Africa, Ghana having a high degree of unmet need overall. Similarly high in Swaziland, Malawi, and Namibia in East and Southern Africa. So let's now turn to East and Southern Africa. Three things are notable about the patterns in East and Southern Africa. First, fewer countries in the region have levels of unmet need exceeding 30%. Second, there's less variation among the countries. Unmet need is notably low, however, relatively, in Rwanda and Zimbabwe. Third, there's no consistent pattern, again, to which age group is more disadvantaged with regard to their need status. Unmet need is substantially higher among 15 to 19-year-olds in Ethiopia, Madagascar, and Namibia, substantially higher among 20 to 24-year-olds in Burundi, Rwanda, and Tanzania, and nearly equal in Kenya, Lesotho, Malawi, Mozambique, and Zambia. Let's take another closer look at comparisons by age. Here we're comparing women in the two youth age groups combined, the red bars representing 15 to 24-year-olds, with women of older reproductive ages, 25 to 49. Be very careful not to call 25-year-old women old. Relative in the higher age group. And these are very broad categories. We're generally looking at 5 or 10-year age categories, but these are just dividing the samples into youth and non-youth. And here we see in West and Central Africa that generally, and this is general, not uniform, 15 to 24-year-olds generally experience greater unmet need. Their need is greater in 12 countries compared to 5 countries in West and Central Africa, where unmet need is greater among older women of reproductive age. However, these differences are frequently small and probably not statistically significant, especially in countries like Chad, Nigeria, or Senegal. Where differences are noticeable, 15 to 24-year-olds do have a greater proportion of experience greater unmet need. East and Southern Africa exhibit more diverse patterns. Unmet need is equal and high among younger and older women of reproductive age in Uganda and Malawi, higher among younger women in Kenya, Lesotho, Swaziland, and Namibia, and higher among women 25 and above in Burundi, Mozambique, Rwanda, and possibly also in Tanzania and Zambia. Now I'm going to turn to a discussion of unmarried women and their current situation. First things that you should notice about this map, well, first of all, there are fewer countries that we have data on unmarried women. but also that there's more red and dark orange in this map, especially in Africa and also in Haiti, indicating that unmet need is generally higher among unmarried sexually active women aged 15 to 24 compared to their married counterparts. One note, the definition for inclusion for need for sexually active, it's sexually active in the last 30 days. And given patterns of sexual behavior that may exclude some people who do have a need at certain points, but unmet need is sort of a snapshot measure at a given point in time. Okay. Looking regionally at demand among 15 to 19-year-olds and 20 to 24-year-olds who are unmarried but sexually active, we see that total demand is similar and strikingly high across all of the regions for which we have data. Unmarried women do not want to become pregnant by and large. Levels of unmet need and proportion of demand that are satisfied, however, vary greatly across these regions. Unmet need is higher in Africa than Latin America and the Caribbean. We have no regional data on Eastern Europe because we just had 2 countries in that region that provided data on youth, and none in Asia or the Middle East and North Africa. Unmet need is consistently higher on average among 15 to 19-year-olds compared to 20 to 24-year-olds. The highest levels of unmet need among 15 to 19-year-olds are found in East and Central Africa, while highest levels among 20 to 24-year-olds are found in East and Southern Africa, among 20 and 24-year-olds in West and Central Africa. Looking country by country at unmet need, we see that among unmarried sexually active women in West Africa and Central Africa, it's highest for these women in Senegal, Liberia, and Chad, between 60 to 70% unmet need. Generally, unmet need among unmarried sexually active youth is higher among 15 to 19-year-olds than it is among 20 to 24-year-olds. These differences are large in Benin, Burkina Faso, and Sierra Leone. Only in Ghana is unmet need higher among 20 to 24-year-old unmarried sexually active youth as compared to their 15 to 19-year-old counterparts. In East and Southern Africa, highest levels of unmet need are found among 15 to 19-year-olds in Burundi. Unmet need among unmarried women is especially severe among 15 to 19-year-olds compared to 20 to 24 unmarried. Starkest differences are in Kenya, Tanzania, Zimbabwe, Madagascar, Malawi, and Mozambique. Only in Ethiopia is unmet need higher among unmarried 20 to 24-year-olds compared to 15 to 19-year-olds. Now, comparing unmarried and married women, ages 15 to 24 together, this chart with many, many bars, the solid bars represent unmarried women, ages 15 to 24-year-olds, and the striped bars are married. Red bars are 15 to 19-year-olds. The gray bars are 20 to 24-year-olds. In this region, unmarried women, 15 to 19-year-olds, are generally underserved relative to their married counterparts. However, numerous exceptions are Congo, Brazzaville, Ghana, Sao Tome. And there are big differences between 15 to 19-year-olds and, between unmarried and married women in Burkina Faso, Chad, Senegal, and Sierra Leone. They're more similar between married and unmarried women aged 20 to 24-year-olds. Here, unmarried women do have more unmet need in Ghana, Guinea, Liberia, Mali, Senegal, and Sierra Leone, with the biggest differences being found in Senegal and Guinea, which also have big differences between unmarried and marrieds aged 15 to 19. In East and Southern Africa, we see that unmarried women are generally worse off in terms of their need status, especially among 15 to 19-year-olds. Exceptions, as there always are some, are for the 15 to 19-year-old category are Ethiopia and Namibia, where married women have higher unmet need. And exceptions in the 20 to 24-year category are Kenya, Namibia, Tanzania, and Uganda. Okay. I'm going to finish with some discussion of how levels of unmet need vary over certain sociodemographic characteristics, looking first at urban and rural residents. Here we see I'm only presenting those countries for which these differences were statistically significant, so I'm able to put both West and East Africa on one chart here. And we see that unmet need is higher among urban married youth in 7 of the 10 Western and Central African countries where these differences were significant. These differences, however, were usually small, except for in Mali and Senegal. Unmet need in East and Southern Africa, however, shows a reverse pattern, being higher among rural women in 4 out of the 5 countries presented here. The differences were large in Ethiopia and Namibia, and only Burundi had higher unmet need among urban youth. Looking by wealth quintiles, poorer wealth categories are in the lighter colors, with richer being in the darker colors. There's no real discernible pattern here. If I had to describe a pattern, I would say that unmet need increases over the first 2 to 3 wealth quintiles and then drops among richer wealth quintiles. But there are many counterexamples. Guinea, Nigeria, and Mozambique show a steady rise with wealth quintile. There's a precipitous increase in unmet need among the richest wealth category in Chad, Mali, Niger, and Mozambique. And the poorest wealth categories are most disadvantaged in Ethiopia and Madagascar. And then we have Ghana that has a peak in the middle with something approximating a normal type distribution. But if you compare the 2 wings of this distribution, we see that young women in the poorer quintiles fare worse than their richer counterparts. Finally, education. We see that unmet need varies significantly by educational status in most West and Central African countries. It's significant in few East and Southern African countries, only Ethiopia, Mozambique, Swaziland, and Uganda. There is a typical pattern, however, and Ghana is just one example used to illustrate here. Unmet need is generally highest among those with either primary or secondary education, with levels being fairly close, fairly similar in these 2 education categories, and lowest among those with no education. However, Ethiopia, Burkina Faso, and Gabon exhibit a different pattern. Here, levels are lowest among those with secondary education or more. And in the case of Gabon and Ethiopia, levels of unmet need are pretty similar among those who have no education and those who have primary education. There's a little bit of a difference in Burkina Faso. So this concludes my presentation. Some of the findings not presented are trends among married and unmarried women, young women, differences in unmet need according to parity, and components of unmet need. The report that will be coming out in about a month will provide information on the proportion of women marrying by age 15 or age 18, proportion of unmarried women who are sexually active, as well as information on fertility desires, both ideal family size, and also the proportion of wanting no more children or wanting to delay a child, and as well as contraceptive use, looking at both use of a modern or a traditional family planning method. Thank you for listening, and I also want to give a couple of acknowledgments. My co-author, Shenjiao Wang, who was very critical in helping me produce the slew of tables upon which these data are based. Josh Colton, who is one of our health GIS experts at the DHS, who helped me produce the maps. And Jessica Yee, our meticulous data checker, who helped make sure that we had all of our decimal points in the correct spot. Thank you.
Thank you so much, Carrie. I think what we're going to do is maybe take 1 or 2 clarification questions, if there were sort of clarifications around the data or the presentation, and then maybe hold the rest of the questions until all of the presenters are done. Are there 1 or 2 sort of clarification questions? I missed that data point. Which country was that kind of questions? Yes. And please introduce yourself.
Hi, Adrienne Allison from World Vision. What determines whether the DHS includes unmarried? Who decides?
Okay, this one's on. What the sampling frame is for any given country, as well as whether it'll be the core questionnaire or the core questionnaire from any range of the modules that we have available, or anthropometric measures or biomarker testing, et cetera, is all determined through negotiations with the country implementing agency. It's very much, DHS tries to standardize what the questionnaire is and what data we collect, but it's also a country-driven process determined by the needs both of the survey implementing agency as well as the mission office and other donors that are supporting that effort. So it's it's really a toss-up. I will say that over time, a greater proportion of countries, more and more countries, are collecting data on unmarried women, and when they do, they're collecting data on their sexual activity as well as their fertility desires. Some surveys that I could not present data on actually interview unmarried women, but either the sample sizes are too small or they don't ask about their fertility desires, so we can't calculate what their need status is.
Any other clarification questions? Great. Thank you again, Carrie. I think it's so important to think about the critical role that this kind of data plays and how it can be used and translated into programmatic interventions and really guide our efforts in this area. I kept looking at your data and have a number of questions around, but what really underlies that? So I'm really now pleased to introduce a couple of other presenters who are going to focus a little bit more on the programmatic work. If it's okay, I'd love to start with Dr. Mengistu Asnake. He is the country representative for Pathfinder International in Ethiopia and is a public health specialist with 25 years of experience in reproductive health, primary health care, child survival, adolescent sexual and reproductive health, community health services, program management, operational research, and clinical service delivery. He is also the chief of party for the IFHP, Integrated Family Health Program, a USAID flagship family planning and maternal, newborn, and child health program, which is led by Pathfinder International. And he also, in a voluntary capacity, served as president of the Ethiopian Public Health Association and as an executive board member of the World Federation of Public Health Associations. He's currently serving, I believe, as the Vice President-elect of WFPHA, and he is also an honorary assistant professor at Addis Ababa University School of Public Health and Institute of Population Studies. So, Dr. Mengistu, please.
Thank you, Monica, for the introduction. Before I go for the presentation, I just want to express that I'm very sad. So many innocent lives were taken away in this city yesterday, and our hearts and prayers goes out to the families who lost loved ones and to those wounded and to those fighting for their lives in hospitals. And I may now go to change the topic of today's interest, which is our noble mission in terms of saving millions of lives related to adolescent and youth. I'll be presenting the experience of Pathfinder International in Ethiopia in meeting the sexual and reproductive health needs of adolescent and youth. And in my presentation, I will also emphasize expanding family planning choices, including long-acting family planning for adolescent and youth. In my presentation, I'll briefly follow the outline as included in this slide. To just give you a little bit of background, Ethiopia is the second most populous country in sub-Saharan Africa with an estimated population of around 85 million. It's predominantly rural country with a large youth population. Almost 44% of the population is under the age of 15. And 1/3 of the population is in the adolescent and youth age group 10 to 24. As per the demographic health survey results of 2011, the contraceptive prevalence rate of modern methods has shown an unprecedented increase, showing an annual increase of 2.7 percentage points for the past 5 years prior to the survey. All these changes, including a decline in the unmet need, are a reflection of the concerted efforts of the government and its partners. In the next few slides, I will briefly highlight specific data related to adolescent and youth extracted from the different demographic health surveys. Adolescent childbearing has many negative health, social, and demographic effects. Children born to women aged 15 to 19 are more likely to die in their infancy and early childhood than children born to older mothers. Women who start having children very young often do not complete secondary school, limiting their future employment possibilities and other life choices. Additionally, starting childbearing young often results in larger families and reduced economic circumstances. As you can see from the map, the percentage of women aged 15 to 19 who have had a live birth or are pregnant with their first child. Overall, 12% of Ethiopian women aged 15 to 19 have begun childbearing. 10% have had a live birth, and an additional 2% are pregnant with their first child during the survey. Except young women in big cities, which was also clearly reflected with Kerry's presentation, such as Addis Ababa, majority of the regions have a teenage pregnancy and a motherhood rate of 10 to 15%. The percentage of married women currently using a modern method of contraception has increased substantially over the past decade when we see the change between 2000, 2005, and 2011. Taking as an example of adolescent women, it has shown an increase from a 3% in 2000 to 23%. Young women showed the most significant percentage point increase in contraceptive use over the last decade compared to the adolescent and adult women, which showed an increase of 5% to 33% during the 10-year period. The level of unmet need among adolescent, young, and adult women currently in the Union has changed in the past decade. The trend represented in the figure shows unmet need for family planning declining in all age groups. It's evident that adolescents still have a higher level of overall unmet need, and specifically very high unmet need for spacing compared with the other two groups of young women and adults. Although there have certainly been some improvement in young women access to contraception, it's still very difficult for young women in Ethiopia to have their needs and rights fulfilled. We all set a lot of statistics every day related to adolescent and youth. Let me now tell you about the story of a young girl who was challenged in search of family planning services to give you a real picture of what life can be for young women in Ethiopia. Almaz, an
We'll grab someone from AV, actually. Oh, you have it? Okay.
Sorry for the interruption. Almaz is an 18-year-old woman living in a small town in southern Ethiopia. Arrived in a nearby health facility very early in the morning. She had heard from her friends that there was a way to prevent pregnancy offered at the clinic. But her trip to the clinic didn't go as planned. Almaz explained, everybody was looking at me and whispering. And even one of the elder women asked me why I was there since the clinic is only serving those older women with children. I was too embarrassed and immediately left the clinic. I don't know what to do, where to go, and get the method to protect myself from unwanted pregnancy. I even get frightened and felt to end up with the same situation like my friends. After discussing the incident with her boyfriend, they decided to go on a less crowded day. After almost 3 hours of waiting, she saw a provider, but again, Almaz was treated very poorly. Almaz explained, the angry-looking nurse asked me what the purpose of the clinic visit was all about, and I explained to her that I didn't want to be pregnant and heard about remedies to prevent pregnancy. The nurse told me that if I didn't want to become pregnant, then I shouldn't have sex and should be in the school or helping out at home and not fooling around with different boys and men. I explained to her that I was not such a type of a person. Almaz was finally offered contraception by the provider, but her preferred method, the implant, was out of stock, and she was forced to return to the facility for a third time. Alma's story clearly represents the day-to-day lives of millions of young girls who don't have access to information, services, and exposed to the existing socio-cultural influences and provider judgment and biases. In responding to the needs of Almaz and millions of other adolescents and youth in Ethiopia, Pathfinder International is supporting the implementation of adolescent youth sexual reproductive health activities within its Integrated Family Health Program, which is a 5-year USAID flagship program on family planning, maternal, newborn, and child health, led by Pathfinder International, implemented in partnership with JSI and other local non-governmental organizations. The program is implemented in 6 regions and 301 districts or waradas, covering close to 35 million people in the country. The program strategies include behavioral change activities at the community level, improving the quality of service at the facility level, specifically giving emphasis at the primary healthcare unit level, which includes health centers and health posts, health system strengthening, and systematic program learning to inform policy and implementation. As part of the adolescent youth sexual reproductive health activities, Pathfinder is supporting the different approaches that include peer-to-peer education in increasing knowledge and bringing behavioral change by working through in and out of school youth clubs and higher learning institutions where majority of them are within the adolescent and youth age groups. Introducing youth-friendly services at public health facilities through the training of health service providers, provision of materials and regular technical support, and closely working with the government health extension program to respond to the sexual reproductive health needs of adolescents and youth. To enable sustainable scale-up of the youth-friendly services, Pathfinder staff worked from the beginning to institutionalize the youth-friendly service in government policies and guidelines. In 2006, Pathfinder arranged for a delegation of representatives from the Ethiopian government ministries, reproductive health-focused civil society partners, and youth association to visit the Gerasho Biz program, a successful Pathfinder-supported multi-sectoral adolescent youth sexual reproductive health program in Mozambique. Having witnessed the possibilities of youth-friendly service at scale, the stakeholders returned and began preparation to bring youth-friendly service to Ethiopia. This resulted in a pilot implementation in 20 public facilities through the support of Pathfinder in 2006-07, and based on the lessons from the pilot implementation, scale-up was done to reach to the current level of 160 public facilities. All of them are linked to peer educators from youth clubs and youth centers. Some of the facilities are increasingly serving married adolescents to address the unmet need. In the past 4 years, over 2 million adolescents and youth have received different sexual reproductive health information within the youth-friendly facilities and through their linkage to the peer educators. Each facility is linked to 20 to 25 peer educators from in and out of school clubs, which helped a lot in creating a better link between the community level activities of the peers and a facility. In most of the peer education trend, we are trying our best to include both male and female to address the gender-related issues in terms of addressing the youth problems. In the past 4 years, over 1.4 million adolescents and youth received different sexual reproductive health services at these 160 facilities. And the last year, the current year only covers the 9 months data, including which is not including the July to September 2013 data. And we are expecting more service numbers to be included there. In all these facilities, providers are providing a range of services that include contraceptive counseling and provision of full range of method, HIV counseling and testing, provision of or referral for antiretroviral therapy, gynecological examinations, sexual abuse and violence counseling, treatment and referral for syndromic management of sexually transmitted infections, post-abortion care, care for pregnancy, and referral for delivery, PMTCT, and other medical services. In 2009, the government of Ethiopia, knowing that there is a need to expand the long-acting family planning services to the lower level, introduced the provision of the one-road implant-on by health extension workers at the community level. And Pathfinder, through the Integrated Family Health Program, supported the initial introduction and the scale-up of activities. Despite the support for scaling up the provision of implant-on, questions in terms of the uptake, particularly about who is accessing implant-on services at the community level, and its impact in responding to the unmet need were unknown. To respond to these questions, Pathfinder has undergone an operation research in early 2011. As you can see from the table, almost 25% of the users were within the age group 15 to 24. And in comparison to the results from the Ethiopian Demographic Health Survey 2011, clients served by health extension workers in our study area were 3 to 4 years younger, which clearly shown the expansion of access to long-acting family planning service at the community level. The results of this study are already accepted for publication at the International Journal of Gynecology and Obstetrics in its September 2013 issue. In order to use the different family planning methods, how those use are there. Data was also collected from 48 health centers after a comprehensive long-acting family planning training in 2003. The data was collected 3 months after the training. As indicated in the table, the data clearly shows that young people are using long-acting family planning methods, and relatively high percentage of the young people within the age 15 to 24 chose implants compared to IUCD. The data also shows that among implant-on and Jadel acceptors, nearly half were within the age group 15 to 24. In these facilities, almost 20% of the clients chose long-acting family planning methods, and the remaining 80% short-acting family planning methods, including natural methods. Even though we are observing different changes in providing services to adolescents and youth, the limited number of youth-friendly service facilities is affecting the response to the huge demand for services. In addition, the provider's attitude towards the different services for the youth needs an improvement in order to provide friendly services. Provider bias that limits them from offering methods to young people means that these methods are not appropriate for nulliparous women and other biases are some of the challenges that prevent youth from getting long-acting family planning services. In order to expand services at the public facilities, the need for resource allocation and inclusion of youth-friendly service trainings at pre-service training level are some of the areas which needs consideration during a wider scale-up. In following up progress on implementation, the lack of age and sex disaggregated data within the health management information system is another challenge which needs to be dealt during any revision of the health management information system. From the experience in the past few years and the different documentation, including the demographic health survey, there is a huge demand for adolescent youth sexual reproductive health services, including long-acting family planning service for youth, which will be an opportunity to easily scale up the program if resources are available. The involvement of decision makers at different levels has clearly shown us its contribution in sustaining the program by creating a better ownership through different support, including budget allocation for expanding youth-friendly service facilities and continuous monitoring of the program. The community facility linkage, specifically using peer educators, also created a wide opportunity in reaching the underserved and vulnerable adolescent and youth. Ladies and gentlemen, we heard about the different challenges young women like Almaz are facing in getting adolescent sexual reproductive health information and services, which calls for strengthening existing programs within our existing 160 youth-friendly facilities and scaling up at least to one facility in all of the districts or waradas based on the lessons learned from the current implementation. Pathfinder will continue to work closely with the government of Ethiopia, donors, and beneficiary communities in documenting the lessons learned and scaling up best practices in order to respond to the huge needs in the areas of adolescent sexual reproductive health. Finally, I just want to take this opportunity to thank the American taxpayers who are financially supporting our program through the United States Agency for International Development, the continuous support from the Ethiopian Ministry of Health, the committed service providers at community level, and different facilities and organizers of this panel at the Wilson Center, in the name of the beneficiary communities and Pathfinder International Ethiopia, for the continued support provided to change the lives of millions and the opportunity given for us to present our experience. I thank you.
Thank you so much, Dr. Mengistu. Are there, we'll take a couple of clarification questions. Yes, let's start here. Please introduce yourself in the front and then we'll go to the back. Yeah. Or should we start in the back? I'm sorry, you're closer.
Hi, I'm Kate. I'm with MSI. I just had a quick question. What types of clinics were these? Were these MCH clinics or were these primary health clinics where the adolescent reproductive health services, where Pathfinder was working?
These are the general health service clinics providing comprehensive services, and in the classification within the country, these are health centers. And each health center is expected to serve 25,000 population in its catchment area. And with each health center, there are 5 health posters, each of them serving 5,000 people linked to the health center.
Thank you. I'm Dr. Hannah Claus from the Teen Star program. Perhaps I missed it, but I didn't see any data on sexually transmitted infection incidents and also the unmarried women who came in for contraception. Multiple partners, any information on that?
Actually, I didn't include those data in terms of sexually transmitted infection, but among the services which are being provided in these youth-friendly services, that also includes diagnosis and management of sexually transmitted infections. I can share you those data easily. But services are provided both for unmarried and married women in those clinics. Initially, most of the services were provided for unmarried youth, but when the friendly services is being known by the users, more and more unmarried youth are starting to use the service there. When the data from Kerry, which was clearly reflecting in Ethiopia, the unmet need among married youth is very high compared to any other. And that whole issue of like the social pressure in terms of like newly wedded couple to get pregnant and get births within the first year is making it a huge issue in terms of the married ones.
Any other clarification questions? Okay, thank you again, Dr. Mengistu. And now I'd love to turn it over to Tanu Diallo. Diallo is the regional representative for Pathfinder International in West Africa and a senior health development professional with 18 years of experience in management and implementation of international health and development programs, including sexual and reproductive health, contraception, cervical cancer, HIV/AIDS, maternal and child health, as well as adolescent and youth sexual and reproductive health projects. Mr. Diallo's expertise comprises design and management of integrated health programs, health system strengthening, organization development, and institutional capacity building. He has collaborated with a range of government entities as well as donor agencies, cooperation organizations, and other key stakeholders. He has a master's degree in statistics and applied economics and speaks, I'm very impressed with this, French, English, and Arabic, as well as multiple other, understanding of multiple other languages. So, Mr. Diallo.
Thank you so much, Monique. Good afternoon. Oops. It's my pleasure to be here today in front of you and to talk about a most important group of population, but often neglected. I'll be talking about the married adolescent and first-time parents. Please, just think about Alma's. Just figure out if she was just getting married and she was going for the first time to her facility seeking for family planning services. So I'll be first presenting a model that Pathfinder International has developed, implemented, and in Bihar, in the Bihar province, it's in the northern India. And from there, I will share with you what we have learned from that experience. And finally, how we adapted it for a new program that we are just starting in West Africa. So why to focus on young married girls and young mothers? Just because often they fall between the cracks. For most communities, once adolescents get married, they are not any longer considered as young girls or adolescents. And we know that most of our youth-friendly services like peer education, school-based program do not reach to them. And in many contexts, including West Africa and India, married girls and young mothers have unique, specific sexual and reproductive health needs. We know that they face incredible pressure to begin childbearing, to prove their fertility, but also to prove their womanhood. But of course, we know that early childbearing combined with closely spaced birth increase the risk of very poor maternal and newborn outcomes, including maternal mortality, and further on limit the ability of girls and young mothers to participate in the community and civil society. Therefore, to reach young married and young mothers require specific and tailored strategies. We have to take into consideration their limited ability due to household responsibilities, but also their lack of autonomy and resources to go places. We also to integrate how little power they have on their husband, but also on the co-wives not to talk about mothers-in-law and other gatekeepers. Our project in India, the Prashar project, took all these factors into consideration when developing a tailored strategy to reach this neglected group of people. The Prashar was a targeted program. It's still a targeted program that aims to directly influence key norms around early marriage and childbearing, as well as reproductive health services. It has been implemented for the last 11 years in 3 district phases, which founding from the Packard Foundation for all 3 phases, and the 3rd phase from both Packard and UNFPA. Prashar had 2 main objectives. Many of you will recognize here the healthy timing and spacing of pregnancies approach that strives to protect the health of mothers and babies by delaying the first pregnancy, but also spacing subsequent ones. The Prashar program was designed considering 2 key frameworks. The first was a life cycle approach. Prashar had specific intervention component for distinctive life stages, all aiming to delay the first birth and space subsequent births. Secondly, Prashar developed interventions aimed at changing the behaviors of individual young men and women, but also influencing the social norms that drive early marriage and childbearing. To do this, Prashar included intervention components which aim to address individual, social, and structural factors that prevent women from delaying marriage and prevent couples from practicing healthy timing and spacing of pregnancies. You can see the life cycle approach of Prashar on the slide here. Since this presentation is mostly focusing on how we learned from and adapted the Prashar project, let me please to go a bit more in depth on the key interventions. The first one was how we took really advantage of the newlywed parties. We capitalized on traditional welcome ceremonies for newlywed, using interactive games and stories to foster dialogue between spouses around fertility and contraception. We also encourage home visits from trained female change agents to discuss sexual and reproductive health, and particularly the healthy timing and spacing pregnancies, including postpartum contraception. We encourage group meetings for both young women and their husband. Female change agent will hold meetings with young women with 1 or more child, and male change agents held meetings with husband. Meetings addressed healthy time and spacing of pregnancies, but also build social support for shifted perception of social norms. And of course, recognizing that the social and structural environment are really key, we supported and we worked with the mothers-in-law to engage them as they are the key gatekeepers of young women and couples. We developed and generated a community-wide support through community activities like painting, theater, street theaters, but also specific engagement for religious leaders and political leaders. Finally, we create some linkages with sexual and reproductive health services through social marketing agents, but also community-based distributors and facility-based contraceptive services. But it's worth noting here that across these key activities, we emphasize gender-synchronized approaches that simultaneously engage both the male and female partners. Prashar was heavily evaluated. The results that I will be sharing with you today are from the phase 1 baseline and endline. Please note that phase 1 was implemented from 2001 and 2005. Phase 1 surveys were conducted in the intervention and selected comparison areas using a cluster sampling methodology to select married and unmarried women, people under age of 25, with 0, 1, and 2 children. Clusters were selected using probability proportionate size when households were selected randomly from within those clusters. As you can see, partial intervention contributed to an increase in contraceptive use. Adjusting for parity, education, caste, and age at marriage, young women in the partial intervention area were nearly 4 times more likely to use contraception. Looking more closely at the use of contraception to delay and space, we can see that young women using contraception to delay their first pregnancy rose from 3 to 16% in the intervention area, with only a slight increase in the comparison area. Young women using contraception to space their second pregnancy rose from 6 to 25 in the intervention area, with just a small increase in the comparison area. What we learned from pressure. We have been implementing pressure for over 10 years, and so we learned so many important lessons. First, we learned that young married women and young mothers do not have decision-making power, so it is essential to simultaneously seek to empower them and engage with the immediate environment, meaning husbands and mothers-in-law, of course, in a synchronized approach. We also found that home visits are an important way to reach young women with limited mobility and high opportunity cost to leave the home. Pressure very much focused on increasing the demand for contraception and shifting social norms to enable young women and their partners to use contraception. While some linkages with sexual and reproductive health services were made, less was done on this front by the projects. So, this is from India to West Africa. So please let me tell you a bit more about the West Africa region and the situation of adolescents and youth living there. First, please note that I'm going to use your data and report on what you were mentioning. 7 West African countries are among the 26 countries with the highest growth rate and highest unmet need for contraception. Of the 20 hotspots for child marriage in the world, 7 are in West Africa. In Guinea and Niger, over 75% of the women were married by age of 18, and over 25% in each country were married by 15. Just so you know, the official age of marriage in Niger is 15, so babies. You will also note the very low use of contraception among young women, CPR being 7 for 15 to 19, being 7.4 in Guinea, 5.9 in Burkina, and just 1 in Niger. Now, considering this context and what we have learned from Prussia, I would like to highlight a very few of the key similarities and differences that influenced our program. I am going to focus on just 3. One being the health system. In India, the government was really committed to the health system. In West Africa, it's growing. I also would like to mention the co-wives. Many of you will be surprised by that. But it's not rare to see a young girl of 15 to be married to a man of 50 to become second, third, fourth, why not plus wives, aggravating the issue of immediate childbearing for the man to prove his manhood. But also, please add to that the influence of the competition on the household resources. For those of you who know West Africa, the resources are being distributed according to the number of children in general, number of boys in particular. And the third one, the point that I would like to point out here is the SERE. SERE is a group. It's a sort of local associations of people, young girls and women at the same age. Keeping all of this in mind, in West Africa, we made a stronger emphasis on strengthening the health system to develop a community-based distribution and create linkages with services. We tried different models of intervention for male to attract older male partners, but also we take into consideration how to engage co-wives, and we supported the small groups activity for young women building on the traditional series. So you can see on the slide a summary of who we are working with, you know it, what we are doing, you can see it, it's essentially healthy time and spacing of pregnancies, and where we are doing it. So far, we are implementing our activities in Guinea, Burkina Faso, and Niger. Hopefully, we'll grow them up. It's important to note something here. We are in the design phase, we really thought about sustainability, something that we learned from Russia, and we decided not to implement ourselves, our activities, but to just make sure that we support local partners to implement the activities. So in Burkina Faso, we are supporting Bukarso, but also SOS Jeune. I would like to insist on that association. It's a local association exclusively composed of young people. In Guinea and in Niger, we are supporting the IPPF affiliate, meaning ANBF in Niger and AGBF in Guinea. And we have been so fortunate to have our centrally funded project Each Way, Evidence to Action, ready to support us in documenting and providing some technical assistance. Thank you, Linda. What has been done so far? Recognizing the success of the ecological model in India, in West Africa, we worked from the structural level. Collaborate with MOH and partners to advance and disseminate youth and adolescent sexual reproductive health strategic plan. Support integration of youth-friendly services at public health sector facilities with added focus on married young women. Just to point out something that we decide not to set up and to support parallel, standalone, youth-friendly services. We decide to support integrated health activities within the existing public health centers. On the social phase, we work to establish community groups, safe spaces to empower young women using behavior change tools like narrative to foster dialogue and knowledge. We encourage home visit, but also we support existing groups and engaging religious leaders. On the individual level, we are supporting the home visit and the community-based distribution of contraceptives. Progress to that. In Guinea, we have been able to support the MOH in finalizing the national youth program for the next 5 years. We have supported them to finalize their guidelines. They have been disseminated and health providers have been trained. We are supporting right now the development of tools, and I have heard you mention the GRID project. We customized the GRID project tools for Guinea, and we are using them to support our activities in Guinea. And just to share something, if you have been working in the region for years now, and I'm from Guinea, this is the first time I'm receiving a letter, official letter from the government thanking us for what we are doing. It's a commitment, but it's also an expression of eager needs. They need it. We are responding to something that they really need. Using focus groups, we have been also able to reach about 900 married adolescents so far, about 8 husbands, and 385 mothers-in-law living in their families. What are the next steps? Of course, to start Niger. You have seen that CPR is just one among our target population. But also to leverage using existing opportunities to delay marriage and scale up a community-based distribution program there, but also document and disseminate and make sure that all other countries in West Africa are benefiting from this experience. Thank you so much. Merci beaucoup.
Thank you so much, Mr. Diallo. Okay, I'd love to, first of all, thank all three of our panelists for incredibly interesting, I think very resonant presentations, and open it up to questions from the audience. Let's take about 3 questions. Please do remember to introduce yourself.
Hi, my name is Jeanette Kesselman. I work with Apt Associates, and I want to thank all the presenters for very interesting presentations. I have a quick question for Mengistu in Ethiopia. You were talking about the program that you've been working with for a long time. They've done really great work, but it's primarily the public sector. And I was wondering, because I know in Ethiopia there's a very large private sector, can you provide any insights or information on what's available or to what extent are there private sector services that sort of cater to young adolescents? And I'm talking about the private sector that's not Mary Stopes and not FGAE, because I know that they have special programs, but there's like so many other private providers in Ethiopia. I'm wondering, are there services for youth? Are they, having also recently worked with the private sector, it's not just for the wealthy. So I was wondering if maybe you could shed some light on what services, if any, are available, and if youth seek out private services even over public services in general, outside of these very special peer groups. But thank you.
Naomi Brodke with the Sierra Club. A question for Carrie on clarifying something that I might have misunderstood, but I think that at the beginning of your presentation you mentioned that one of the countries with a disproportionate need was Haiti. Is the data that was collected post-earthquake, and if it was post-earthquake, did that also take into account the disaster relief and often lack of family planning and reproductive health services that are part of disaster relief?
We're all in the back. Hi, it's Kate again from MSI. Again, another question for Ethiopia. When you scaled it up, I'm wondering a little bit more about the logistics. Who covered the costs, the training, the supplies, and has this become standardized within the public sector of Ethiopia in terms of policy or curricula at all?
Okay. Maybe we can just do one more question over here. Thank you. Yeah.
Thanks, Dave Rabinowitz. This is for Mr. Diallo. In the issue of increasing spacing between pregnancies, has anybody looked at encouraging extended breastfeeding, which tends to seriously reduce fertility?
Okay, let's start with those 4. Dr. Mengistu, do you want to tackle your 2 questions first?
Thank you so much for the questions. In terms of the private sector in Ethiopia, specifically the private for-profit sector, is a recent phenomenon in terms of flourishing, specifically in the urban and peri-urban areas. As you heard from my earlier presentation, almost 83% of the country is rural, and it's only that 17% which is an urban area. So looking at, a national scale type of activity, still the public sector dominates in terms of serving the adolescent and youth. But we need also to see youth by themselves can go to this private sector, either clinics, pharmacies, or other service delivery points to get certain services. Mostly sexually transmitted infections are being dealt in most of these private for-profit clinics and also drug outlets. So training them, the ministry is doing it to a certain extent to bring some of them into the different training activities. But there is a need to do more in terms of the private for-profit sector. Even though there are more in the urban, peri-urban areas, still they will play a major role in responding to those needs. Scaling up user-friendly services. First of all, the initial thing before we go for starting services in the different areas is we work closely with other partners and the Ministry of Health in terms of some of the guidelines, standards. And the first thing in that line was the ministry produced an adolescent youth sexual reproductive health strategy. Within that strategy, the minimal standard for user-friendly services, the MND guidelines, and all those things are included into that one. So that's the first thing. The second issue is it's not a standalone service. It is within the other comprehensive services, but providing a friendly service within the facility rather than making it a standalone. In line with that, there may be certain costs like modifying some of the rooms in terms of either partition, having a little bit of waiting area within that facility for use to wait there. This type of things are there. In the initial phase, the project is putting some resources in improving that, including audiovisual materials such as TV, video sets, where youth can easily have an entertainment activity until they wait for the different services. But one thing we learned is some of the facilities where there is no user-friendly service are coming to us or to other partners in introducing that, using their own money. In Ethiopia, through the healthcare financing, all hospitals and health centers are allowed to retain 100% of the fee collected in the facilities and to use it for improvement of quality of services. So few facilities already used some part of that resources to improve the quality of service related to user-friendly service. So we may need to do more lobbying, both at the regional health bureau level and also at the facility level, in terms of how can they use their existing resources to improve this type of things. But standard is already there. The only thing is how can we use that standard to reach probably close to 3,000 health centers in the country. So that's the whole issue.
Carrie, do you want to tackle your question about Haiti?
Sure. The data, is this on? The data that I was presenting today come from the most recent survey, which is a 2012 survey that was just released in the last 2 to 3 months, I believe. So those are very, very current data. In terms of trends over time, whether there's been a jump most recently, between this most recent survey and the previous 2 surveys, which were, I just looked them up, collected in 2005, 6, and 2000. I'm just analyzing those data, so I don't know if this is a significant increase over previous surveys. But I will say that in Haiti, levels of unmet need have been consistently much higher than any of the neighboring Caribbean countries or Latin American countries, and that this is a pattern that is typical. So I don't know, and I don't know to what extent these data represent that type of change from an influence like a disaster like that.
And Mr. Diallo?
Thank you. I just would like to introduce Karis Simon, who is my colleague who is teaching me many things about India. She will help me responding to some questions. About breastfeeding, that's just one of the core elements of a healthy time in spacing of pregnancies. It's a package of activities and services, and breastfeeding is among the services.
I just wanted to quickly raise an additional point about exclusive and extended breastfeeding, which is in sort of the discussions we've had around not just the child survival, but also around looking at gender norms. I think that there are a host of other potential factors that may play a role in a woman's decision or ability or desire to really engage in exclusive and extended breastfeeding, and men's support for that too. Okay, shall we open it up to other questions? Maybe the two over there? Three.
Hi, I'm Liza Douglas from Plan International USA. My question's for Mr. Diallo. In picking which of the West African countries to scale the Prachar program, did you choose based on data about the need? Was it opportunistic where Pathfinder had some other programs to build upon? Was it political context? Surely not if you chose Niger. I'm just curious, we saw the data that, Senegal, Liberia, Ghana sort of come to the top, but those aren't the countries you chose. So if you could just tell us a little bit about your thinking on that.
Hi, my name is Afif Abdurrahman, and I'm an independent consultant working on gender and behavior change in Ethiopia. And my question is not about Ethiopia, it's actually for Mr. Diallo. Sorry, Dr. Mengistu. My question was, for the increase in demand of contraceptives from impact of your program, is there any data on the types of contraceptives that women were, that women wanted to use or were using? Was it implants over, I don't know, any of the other contraceptives that were part of the program? If you could provide some information on that, that would be helpful. Thank you.
Okay, sorry. Amy Phillips Bursch with Population Connection. I just had a quick question for Carrie. I was wondering, in your numbers it showed that unmet need was actually lowest among the people with the lowest education, and I was wondering what it is. Is it lack of knowledge that people don't understand what's available, or don't have the desire to space pregnancies, or if you could go into the reason behind that a little bit, if you know.
I think there was one more over here, right?
This question is for Mr. Diallo. I was just wondering if you could talk more about your experience working with the governments. I'm just really curious about that. You pointed to the difference between working with the Indian governments versus the African governments, and maybe any strategies that you all have used to really try and gain support, like that one letter that you got. That would be nice to know. Oh, and sorry, Georgetown University.
Great, thanks. I'm wondering, Carrie, if we could start with you, and maybe if I could just tack on to that question a little bit more about unpacking some of the data that you've seen. I think this speaks to the real need for not just sex and age aggregated data, but broader sort of understanding of what that data is actually showing.
Well, I have sort of a love-hate relationship with these types of comparative reports. These comparative reports extract from a lot of data, but they don't allow for a lot of analysis. So they're really good at raising a number of questions that I really want to delve into and don't have firm answers to. Mm-hmm. So one of the things that it does seem a bit of a puzzle and a little bit counterintuitive, but it could be a couple of things going on. One of the things that we have to remember is that unmet need is a proportion. And so when one proportion is lower in one group than in another, you don't know whether it's because of differences in the numerator or differences in the denominator. It could be that the fertility desires, for instance, of those who are in the lowest education group are substantially different from those with higher education. We don't know, for instance, whether, you have people who have unmet need, you have people who have no need, and you have people who have met need, and we don't know whether those who whether we're seeing in most countries lower unmet need in the lowest education group because their needs are being met to a greater extent than their more educated counterparts, which might be implausible, or whether it's because there is less expressed need in this group. We just don't know. That I'm going to be looking at those components in subsequent sections of the report, but for the national data as a whole, not necessarily disaggregated by education or wealth quintile, et cetera. And that's the type of analysis that really needs to be done to figure out, why it is in any given group, why unmet need is particularly high or particularly low.
Thanks. And Mr. Diallo, I believe you have a range of questions.
I have three, in fact. I'm going to start by the last one, experience working with government. Please just think about the turnover of the staff at the government. It's one of the key problems that we are having in many countries. But we are supporting those local partners to support the government. For instance, in Guinea or in Burkina, I didn't mention that what we are doing is just to provide the technical assistance to AGBF so that they will be able to support the government. And what we are doing, because Guinea and Burkina are both Francophone, French-speaking countries, we are just going to use the Guinea materials for Burkina. So it's exactly the same strategy that we are using in many other countries. The most demanded contraceptive method is pill. The pills were the most solicited method, but also in second we had condoms and depot.
What was the third one, sir?
The condoms and depot. Oh. It's in India. And that's the most difficult question for me, how we made the decision about countries. I remember we started with Mali, and then Mali collapsed. And we said, okay, what are we going to do? Niger, it's clear. We know, from the beginning, we knew that we should go there because nobody's there, in fact. Very few partners are right now in Niger. But Burkina Faso was chosen just after Mali collapsed, and we said, okay, let's move to Burkina. And Guinea, we had the infrastructure, so it was just based on that.
Great. We take a few other questions, another round. One over here, and then Sandeep.
Hi, I'm Victoria Riekers, and I work in USAID's Office of HIV/AIDS with Monique. And my question was for Dr. Znaki. Sorry about your name. When in these youth-friendly clinics, when girls come in for contraceptives, do you give them any type of sexual education or education about STIs? Because I think that would be a perfect opportunity. Thanks.
My question's actually for all of you. I was wondering if you could speak to the corresponding infant or maternal mortality rates in the regions, and if that had an impact on rates there, or your decision around work there. And then Carrie, too, with regards to the research, did you look at corresponding rates as well?
Okay, I'm going to quickly throw in couple of questions then as well. The first is maybe just my own lack of understanding, but both of you have highlighted youth-friendly services in different contexts. And USAID, we talk about youth-friendly services a lot. I'd just love to ask from your perspective, so what exactly comprises a youth-friendly service? Because you've highlighted sort of the services that are provided, but my sense is that those are services that should be and commodities that should be provided in any sort of comprehensive health service, and perhaps really the goal is the sort of the changing of the provider's attitudes, the training around that, and related to the question about scale up, then what exactly is it that would comprise that standard of youth-friendly service? So I guess I'll throw that in for both of you. And maybe Carrie, you want to start with yours?
The short answer is no. Actually, that's not my area, but we do have someone, and it was just beyond the scope of this particular report. We do have someone who is working on a report that should be issued in the next couple of months, looking at data quality related to infant mortality figures, but that would, of course, also present those figures. did not look at those and did not look at those in relation to anything regarding unmet need or spacing or anything like that. We also have an analytical report that is coming out that is looking at infant mortality and birth interval, birth spacing. That'll be coming out.
In relation to the youth-friendly clinics, since they are linked to peer educators, in each of them like 20 to 25, the initial contact started outside even the service facility with their peers to discuss about issues of sexuality, issues related to sexual transmitted infection, HIV, it's all those discussions will start at that level. Those coming to the clinic specifically relates to when they are in need of a specific services. But the peer educators are being used as a very good link between the community and the facility. In addition to that, even youth try to select those dates to come, specific dates when their peer is there in the facility, rather than going simply to the clinic and being confused in terms of how those different services are being given. So sexuality education is part of that, but one of the things which we are advocating is, I mean, we need to go even beyond the facilities. I mean, there was a time where the family life education was started in the schools. We have also good examples of Teen Star program in some of the elementary and junior secondary schools in few areas, where having those things in the schools will help a lot in terms of the link between the school and also the clinics in the different areas. When it comes to I mean, we are not trying to compare in terms of like mortalities, but in Ethiopia, as an example, we are looking at, I mean, a change in terms of infant and child mortality. And I mean, few days back in one of the UN meetings, it was even declared we reached the MDG4 targets for infant and child. And family planning also played a major role in terms of that, in addition to the other child survival interventions. So that's one area where we can see. Youth-friendly services, I mean, there are several components. It's not only about a list of services being provided in one specific corner of the facility. It starts from the whole issue of the attitudes of providers, and those providers need to be willing to work in those facilities. In addition to that, the training given for these providers will give them an opportunity how they can interact. It's not about clinical knowledge, but their skills in counseling, their skills in bringing the youth at that level is not only for the youth. Now we are starting to have women-friendly services to increase the skill deliveries at the facilities. All those things are not related to specifically to clinical skills, but the counseling skills, their communication skills with the clients, and also those people who are in need of the services. In addition to that, in some areas, for example, the government is training providers, but they are not linked to the community linkage. So within these youth-friendly services, the most important part of it is there is someone in the community who can tell to their peers that if they need any of these services, they can easily get it within these facilities rather than going to different places. In the past, they were avoiding those facilities because services were given with all the adults and everyone, and they have to wait for longer hours. Waiting time is another determinant factor in terms of the friendliness of those facilities. The other thing is availing those services from the same provider without creating a longer referral linkage or flow within the facility. Sometimes, if they can get all the family planning methods, including short-acting, long-acting, within the same place, rather than being referred to another provider, they would like to get it that way. Including HIV testing and counseling is done within the same room, not referred to another VCT clinic within the facility. So it's more of like bringing those services in an integrated way within the facility without creating a cumbersome situations, both for the provider and also the client. But the most important part of a community facility linkage helps a lot in terms of creating that user-friendliness.
Do you want to add on to that? No, yeah, very eloquent. And I
Just like maybe to add two things on what he has already said. One is about reorganizing the services at health center level, just to make sure that he mentioned about integration, of course, and reorganizing the services and making sure that sometimes specific times, specific windows of times are allowed to. The second point is a referral, two-ways referral between the community and the health center.
I think we're seeing in the HIV context some very, very similar sort of need to really look at community and clinic linkages and meeting the needs and addressing the risk and vulnerability of young people. So very, very important. There are other, okay, in the back.
Hi, I'm Allie Glinsky with ICRW, and I have a question that's kind of for all of you. Carrie, you presented such great comprehensive data on unmet need, but kind of how Monique opened this session, we know that adolescent fertility decisions are made in the confines of social pressures, and so there's often wanted pregnancies among married adolescents or unmarried adolescents, and so how do you kind of deal with understanding that when you're analyzing the data? And then for those of you who are implementing programs, have you found a way to kind of more accurately measure changes in adolescent desires and achievement of those desires?
One more question? Okay, go ahead. Over here.
In a sort of follow-up to that question, in South America, especially Brazil recently, there's been a substantial fall in fertility. And they've discovered that a lot of that is due to the telenovelas, basically television soap operas, where the characters serve as role models and have few children. Is anybody looking at doing that in Africa? I mean, coming up with using the mass media to create role models and change expectations.
And I think you'd have to do a little bit of an analysis first of the role of that kind of mass media in the context. I want to just throw in a quick addition to both of those, which is maybe I'd be very interested. I know a number of people look at specifically at gender here that I'm seeing in the Petra Project, and a little more maybe fleshing out of how that works. You highlighted sort of the working with men and women across the life cycle, but sort of a little bit more about sort of how do you approach them? How do you engage in this discussion? And some of the lessons that you're learning about that as you're talking about changing attitudes, norms that are potentially deeply entrenched. Should we go with those three questions then? I think all three of you can tackle.
All right, well, the definition of unmet need is a very good one at an aggregate level. It's kind of a poor measure for trying to determine whether any one particular woman is needing services or not. And it's this kind of a funny indicator in that we're not asking women one simple question to establish unmet need. It is it's figured out from, in the streamlined version that the DHS now uses, I believe it's 13 separate questionnaire questions, the core ones of which have to do with fertility desires and also about their current contraceptive use, but also it relies on their reporting of sexual activity for unmarried women, which we know can be problematic. So categorizing women's need status can be a little bit tricky, and we're left with basically what their self-reported desire is for having a child within the next 2 years, at some point after 2 years, or no more children whatsoever. And there are sort of two things in terms of wanted fertility there. There's we're taking people who want a child within the next 2 years, who say that that's what their desires are, as not having a need. And when in fact, answering that question might be a combination both of her own desires and her processing of the social pressures that she feels from the community, from extended family, and from her spouse or partner. And then also, in terms of whether 2 years really is the right line for figuring out what her status is right at that very moment in terms of needing contraception or not. And that is an issue that, that's where you sort of see the distinction between creating an indicator that works at an aggregate level and something that you'd want to tease out in client-provider interactions in a clinical setting where those might not necessarily match up.
Well, to respond to some of the issues related to social pressure, one of the work which we are doing is we try to include every social group. I mean, in terms of like religious leaders, informal leaders, and even champion among the youth to be part of the program activity. In Ethiopia, the government has introduced a flagship program of the Health Extension Program, where in the past, most of us were working with volunteers. And when projects end, that was a huge issue, sustaining those programs. But with the Health Extension Program, these are formally trained people who are assigned in each village. 98% of them are women. It's only in few of the urban and pastoralist areas where there are male included into the program. Paid by the government under the payroll of the health center and working at that level. And their major activity, which I want to link with this one, is to create model families. And among those behaviors, those families who are practicing those behaviors are selected as models. And the whole principle of those models are working with their neighbors. So to diffuse some of the practices they are using it to reach to the next level. Initially, there was this trend of training model household for a certain period of time. The current trend is to link 5 of the household to one model leader in their neighborhood to work together. They don't need, huge time, but they can discuss in terms of maternal and child health issues. They can discuss different issues which they can share each other. And that created a huge change in terms of specifically listening to their neighbor rather than a health provider coming from a distant place who may not even have the day-to-day feeling of that specific family. So that's another area where we try to use also as role models which can create change within the community. And for some of our contraceptive use figures, that played a major role. Another area which I want to include here is sometimes availability of services in a very nearby place versus availing that services for free anywhere in a distant place has a major role in changing those things. A very good example is when the One Road implant was introduced at the community level. From the data we have among 7,000 users initially, 22% were very new to family planning. There were new clients. And the whole issue is they had injectable contraceptives in the village, they had pills, they had condom and other choices, but they were not using it. So the whole issue of like using role models, using with the different leaders, both formal and informal, but at the same time, availing services to the lower level, which gives the opportunity for women and families to choose what they need from those levels, had a lot of influence into it.
Very quick comment on your question. I think the perfect example is Niger. Have you seen the fertility rate, 7 point something? And you look at the unmet need, almost, it's not the most, we have seen Ghana and some other countries presenting some indicators. So we know that we have to create the demand, we have to generate the demand, we have to orient people. You have to make sure that the information is there for potential users. We know that something is missing between the use of family planning and the needs. Just to comment on your point, completely correct. That's one of the best ways now to make sure that people get the information and use the services. We are supporting, for instance, in Guinea, they are even, when we organize the girls in groups, it's just for them to get together to discuss, but also to take that opportunity to just watch a movie or something about Brazil or Mexico, it doesn't matter, but also to support local production of movies so that people can learn from each other. Gender. It's interesting. Most of people right now, when they think about gender, whenever they work with women separately, they think they have done gender. That's the first step. The second step is to work with men, but also to work with them, to combine them. That's what we do. We engage a dialogue in couples so that they can get together, discuss about their sexual and reproductive health plans. You have just a sort of plan for their families.
Are we? Okay. Are there any final burning questions? We're unfortunately out of time, and I think this rich discussion could go on for several other hours. Are there really quick burning questions? So the webcast will also need to be ended very soon.
I don't know if we can cover this really quickly, but one burning question was about Ghana. I noticed a lot of the stats, everyone was talking about Ghana having a very high unmet need. That surprised me, given Ghana's economic status and everything else. Is there a quick, short answer on why that is?
I can't imagine that's going to be a quick, short answer, but we'll, we'll.
No, it's just the level of information. Look at the level of education in Ghana. Many people are really informed. They know their rights. It's not. We are not talking about Niger or Burkina here. Ghana is one of the, it's just Ghana. and it's interesting. If you look at Senegal, it's almost the same thing. In Senegal, I was with USAID, the local USAID Dakar 2 weeks back. We were discussing about the same things. We are surprised to see the indicators about Senegal and the level of funding. But Senegal is far in West Africa. But it's normal when people get the information, they are informed, they know where to find the services, they want to use them, and they cannot get them. It's normal that the unmet need be that high.
So, I was just going to add that it could be one of those situations where unmet need is particularly high because demand is particularly high, as opposed to having low overall demand, but also really poor service delivery, for instance. So.
Okay, I would love to once again thank all of our panelists and the Woodrow Wilson Center for sponsoring this. Thank you very much for attending.